MRM, modified radical mastectomy. Modified radical mastectomy. So to understand this, please understand this picture I am drawing. So modified radical mastectomy, you are going to understand from this picture. So now modified radical mastectomy is removal of entire nipple, areola, and we remove the entire breast tissue. We remove the entire breast tissue, nipple, areola, entire breast tissue will be removed, and along with this entire breast tissue, we will also remove the pectoralis fascia. Please understand, I am not telling muscle, I am removing the pectoralis fascia. So because pectoralis fascia is over which the breast is sitting, so nipple, areola, breast tissue and pectoralis fascia is removed. Pectoralis fascia is removed, and along with this thing we will also dissect the axilla and remove the axillary nodes, known as a procedure, axillary dissection procedure. So axillary dissection procedure is done, in which I will remove level 1, level 2, level 3 nodes also. So modified radical mastectomy is a procedure in which nipple, areola, breast tissue, pectoralis fascia, axillary nodes are all removed. And the boundaries of MRM are the lateral boundary, laterally it is bounded by latissimus dorsi. Medially it is bounded by sternum. Superiorly it is bounded by subclavius muscle. Inferiorly the boundary is 2 centimeter below the mammary fold. 2 centimeter below the breast fold, inframammary fold. Below the inframammary fold, 2 centimeters. So this is the boundary. The subclavius muscle, sternum, 2 centimeter below submammary fold, and we have to go up to the latissimus dorsi. This is the boundary of modified radical mastectomy. What all things to be removed is, in this boundary, except the skin, we have to remove everything underneath. We have to remove everything underneath. And what is the structure preserved in this? That is a repeat NEET PG level question and also final year's question. What are all structures preserved in MRM are: number 1, A, number 2, B, number 3, C, number 4, D, and number 5, muscle. Remember like that, A, B, C, D, muscle. So what are the structures preserved in MRM? A for axillary vessels. A for axillary vessels. B for Bell's nerve. Bell's nerve. C for cephalic vein. Cephalic vein. Nerve to latissimus dorsi. D for nerve to latissimus dorsi. That is known as thoracodorsal pedicle. Nerve to latissimus dorsi. I will explain you what is it later. But remember, that is known as nerve to latissimus dorsi or thoracodorsal nerve. Okay, so please don't forget the structures preserved in MRM are axillary vessels, Bell's nerve, cephalic vein, nerve to latissimus dorsi, and muscle. Okay, and muscle will be removed. What muscle is removed? What muscle is preserved? What are all the structures preserved are A, B, C, D, and pectoralis major is preserved. High yield MCQ for your exams. So pectoralis major is preserved. What are the structures preserved? Please remember this mnemonic: A, B, C, D, muscle. Okay, so now I am telling you here and there axillary dissection. What do you mean by this axillary dissection? Please understand, axillary dissection is a part of MRM. It is also a part of MRM, modified radical mastectomy. It includes axillary dissection also, in which what I will do is, I will remove all the axillary nodes within this boundary. What are all the boundaries means? Superiorly it is bounded by axillary vessels, axillary vein and axillary artery. Superior boundary is axillary vessels. Apex is by a ligament here. What ligament is there in the apex? This is the apex. Halsted costoclavicular ligament. Costoclavicular ligament. Halstead costoclavicular ligament is superiorly seen at the apex, axillary vessels superior boundary, and medial boundary is by this nerve. What is this nerve? Medial boundary is running, the nerve is running here. That is known as long thoracic nerve of Bell's nerve. So please remember, the boundaries of axillary dissection is a high yield MCQ for you. Superiorly axillary vessels, medially Bell's nerve running here on the chest wall, and laterally I told you there is a pedicle. So please see this pedicle. This is vein, this is artery, and they will carry a nerve also to the thoracodorsal. This is a pedicle known as thoracodorsal pedicle. Very, very important, you should preserve it. Thoracodorsal pedicle. So if you damage this nerve, that's all. The thoracodorsal nerve is damaged. The thoracodorsal nerve, if damaged, latissimus dorsi will lose its nerve supply. Okay. So please remember, thoracodorsal should be preserved. And inferior most boundary is what? Usually you will get confused in this only. It is angular vein. So in an axillary dissection, what are the structures act as a boundary means? Superiorly axillary vessels, medially Bell's nerve, inferiorly angular vein, laterally thoracodorsal pedicle. All the structures within this yellow square should be removed out. Please remember, all the structures within this yellow square will be removed out, and all the nodes will be sent for pathological examination. So how many nodes should I remove minimum? If I am a good surgeon, if I am a good oncosurgeon, minimum nodes should be removed as 10 nodes. Please don't forget. In an axillary dissection, to say it is completely done, the number of nodes should be removed as 10 nodes. 10 number of nodes should be removed. So in this axillary dissection and MRM procedure, what is the most common nerve injured? I am discussing everywhere nerves. What is the most common nerve injured? Can you tell me? It is nothing but a cutaneous nerve, intercostobrachial nerve. So intercostobrachial nerve is the most common nerve injured in axillary dissection and MRM. In axillary dissection and MRM, the most common nerve injured is intercostobrachial nerve. So other nerves which can be injured are Bell's nerve can be injured. Okay, Bell's nerve can be injured, resulting in winging of scapula. Winging scapula can happen if Bell's nerve is injured because of loss of sensation of serratus anterior. Intercostobrachial nerve is only a cutaneous nerve, so no need to worry. The patient will have paresthesia in front of chest. In front of chest and arm, they have paresthesia, only cutaneous loss. So nothing big to worry. But if Bell's nerve is injured, patient will have winging of scapula. And if nerve to thoracodorsal pedicle or nerve to latissimus dorsi is injured, patient will have inability to shrug the shoulder. Shrugging is absent. Shrugging of shoulder affected. And other nerves which can be injured are medial and lateral pectoral nerves can be injured. Medial and lateral pectoral nerves supplying the pectoralis major and minor will be also injured. So the various nerves which can be injured in an MRM and axillary dissection operations are intercostobrachial nerve is a high expected MCQ. Please don't forget. Bell's nerve causes winging scapula, nerve to latissimus dorsi injury causes shrugging of shoulder, and there will be medial and lateral pectoralis nerves will also be injured. So this procedure is known as MRM. And now let me tell you the steps in MRM and complications following the MRM. So patient is put in supine position. Patient is put in supine position on the table with the arms extended outwards like this. Arms extended at least 90 degree outwards, it should be extended. 90 to 120 degree, you should extend the arm. And now you have to make an incision like this. What is the name of this incision in the breast? On the breast, the incision made is an elliptical incision. Elliptical incision is made. That elliptical incision is known as Stewart's incision. That is known as Stewart's incision. Elliptical Stewart's incision is made, and you raise the skin flap above and below. The skin flap is raised above and below. up to the boundaries I told you. Skin flap is raised above and below, and then remove the breast tissue. Entire breast tissue and the pectoralis fascia is removed, and this is how you get the specimen. This is the skin along with nipple areola will be there, along with the entire breast tissue, and along with the same specimen we also remove all the axillary pad of fat containing all the levels of nodes. The most toughest step is to remove the axillary nodes, because there is one muscle coming in between, that is pectoralis minor muscle will be a disturbance when you go for axillary dissection. So to deal this pectoralis minor, we have three maneuvers. What are they? I can cut and remove the pectoralis minor. Cut and remove. What is the name of that maneuver? During MRM and axillary dissection, cut and remove pectoralis minor. Pectoralis minor will cut and thrown out. It is known as patties. Remember patties. Patties, cut and remove. Retract. You retract from this side. Call the first year PG. Ask him to come and retract the pectoralis minor. The retractor first year PG himself is known as Achin class. We call him as Achin class. So cut and remove patties. Achin class retraction. Achin class is retraction. Then cut and resuture is scanlon. Cut and resuture is scanlon. So in patties we can remove level 1, level 2, level 3 nodes. In Achin class we can remove only level 1 and level 2 nodes. We cannot remove the infraclavicular nodes. Okay, so patties, MRM, Achin class modification only 1 and 2. Scanlon we can cut and resuture, we can remove all the nodes. 1, 2, 3 nodes are removed. So now all the nodes are removed and surgery is completed, and the patient is going for a closure of the skin. So the closure of the skin is nowadays done by subcuticular sutures. So this question came in exam. Subcuticular suture of choice for closing an MRM wound is what? Monocryl. Monocryl is a latest suture used for subcuticular. It is nothing but polyglycaprone. It is a question from general surgical aspects. So polyglycaprone, it is used to close the subcuticular suture. And before closing, please don't forget, we always keep a suction drain inside. Suction, Romovac suction, vacuum suction drain is kept on both sides. So why I am keeping a suction drain in a MRM? Because the most common complication of this operation is what? The most common complication of MRM operation is seroma collection. Because of the seroma collection, I always keep a bilateral, two drains we keep inside. One in the bed of the surgical area and another in the axilla. We will keep two drains, and I will remove it on which day? Bailey says remove it on 5th post-op day. Seroma collection will happen. Therefore, you should retain it at least for 5th post-op day. You have to remove. So remove it on 5th post-op day to prevent the seroma collection. Other complications are the nerve related complications. Already I told you. So the most common nerve, most of the time it happens, is intercostobrachial nerve. We can get other complications like flap necrosis. Patients may get flap necrosis. In long term, patients may get lymphedema of the arm. That arm can get lymphedema. And if you give radiotherapy added along with the surgery, they will develop lymphangiosarcoma. That lymphangiosarcoma development because of surgery and radiotherapy, that syndrome is known as Stewart-Trevis syndrome. That syndrome is known as Stewart-Trevis syndrome. So please don't forget, these are the various complications of MRM and axillary dissection. So modified radical mastectomy, the complications and various issues you should not forget. It is a high yield topic for your exams, MRM. Okay, so please don't forget MRM.